morning, good afternoon, and good evening, everyone, depending on where you're logging in from. I'm Neeti Daftari here on behalf of the Circle of Cleft Professionals. At today's webinar, we will have psychologists Dr. Nicola Stock and Dr. Bruna Costa sharing with us strategies that could be used by cleft teams to support positive psychosocial outcomes for patients and their families affected by cleft. We will be having simultaneous interpretation in Spanish for the entire duration of this webinar, for which we have Melanie and Felipe, who have joined us from Chile. At the bottom of your screen, you will see an interpretation button. If you would prefer to hear the rest of this webinar in Spanish, please click on that button and select Spanish. If you would like to continue in English, please click on English. That will be particularly helpful during the discussion. Some quick tips on how to make the most of your participation at this webinar. If your bandwidth allows, please keep your video on. As Hugh suggested, use chat to introduce yourself to the group and tell us where you're from. Display your full name on your Zoom screen. At any point during the presentation or discussion, feel free to type in questions or comments or to use the Zoom reactions. Please do keep yourself muted during the presentation or when not addressing the group during the discussion. When we open for discussion, you can share your thoughts or ask questions either via chat or on video by using the raise hand button. This is how the webinar will flow. We begin with a COCP update, followed by a presentation by Dr. Stock and Dr. Costa for the first half hour. This will then be followed by questions and discussion for the remaining half hour. We have three core objectives at the COCP. Our aim is to facilitate collaboration and networking amongst cleft professionals, to communicate the impact and learning that's happening within cleft care, and to support the growth of local teams in implementing comprehensive care. Our members are spread across the globe. We are a network of over 750 cleft professionals from over 80 countries. A shout out to these 11 international charity organizations who have come together to make the COCP and all of its activities possible. Back to you, Hugh.
Thanks, Neeti. Again, I'm Hugh Brewster in Toronto, Canada, here on behalf of the Circle of Cleft Professionals, and I'm really excited about this topic. For those of you who have been following along on our emails, this was a key element that we discussed in our virtual conference called Solutions for Comprehensive Cleft Care, where the idea of how to engage full teams in psychosocial care was really motivating. We had a wonderful discussion, and we'll talk a little bit more about the next steps out of that. But one part of that momentum is inviting some experts to come and share a little bit of their journey of thinking through how psychosocial care can be woven in, especially for low and middle income country cleft teams. So we're delighted to introduce to you Dr. Nicola Stock and Dr. Bruna Costa. Dr. Stock, as you can read here, is a research psychologist at the Center for Appearance Research, and Dr. Costa is a research fellow at the same center. Both of them have a huge focus on cleft and craniofacial conditions. You won't want to miss this discussion. And I think the open question that we're all asking for you to think about as you listen to their presentation is, how does this apply to your team? What are the next steps you could take that would really move towards facilitating positive psychosocial outcomes? What are your questions about how to move forward? And I know that Dr. Stock and Dr. Costa will be delighted to engage with this in our discussion portion coming up soon. But without further ado, let's pass it over to our experts. Dr. Stock, Dr. Costa, take over, and I'll stop sharing my screen here.
Thank you, Hugh, so much, and Neeti, for such a lovely introduction. We are naturally very delighted to be here. So nice to see so many people tuning in from all over the world, despite time zones and other challenges. So I'm hoping that I am successfully sharing my screen with you now.
Looks great.
Fantastic. So now I will, without any further hesitation, hand over to my colleague Bruna.
All right, so good morning, good afternoon, good evening, everybody, wherever you are. It's really exciting that you're all on here. Thank you so much. So as Hugh and Nicola have already mentioned, our webinar today will be focusing on the issue of psychosocial outcomes in cleft and what that means for kind of various teams. And as Hugh just noted too, what that means particularly in an LMIC context. So just to give you a bit more concrete information about what we're going to do, we're going to spend some time now just introducing ourselves and the centre that we come from, just to give you a bit of context about our work. We're going to define psychosocial health, so what we mean by that and what might be some of the issues that contribute to overall psychosocial health in cleft. We're going to consider what the literature suggests might be some of the common psychosocial difficulties experienced by patients with a cleft and also families of individuals with cleft. Nicola will take us through some screening tools that we've done quite a lot of work on over the years that we feel are the best for identifying and screening psychosocial difficulties in cleft. And then we're going to think about how we might start to address these. So what conversations should we be having with patients? How should we, what terminology should we use? How should we frame these questions? So as Hugh just said, a really kind of applied focus, what we can do after this webinar to improve our practice. Thank you. Just to give you a very, very quick introduction about CAR, you'll hear us speak about CAR. That's just the acronym for the Centre for Appearance Research. So at CAR, we're world leaders in interdisciplinary research on the role of appearance in people's lives. So that's quite broad. And with my explanation today, hopefully you'll see how we kind of all focus in different areas. There's about over 30 of us, so everywhere from professors to PhD students, all kind of working in this area, with the common theme being, what's the role of appearance in people's lives? About half of our membership base focuses on body image, and that's just body image in the general population, disordered eating, interventions for young people. And the other half of us focus on what we call visible differences. So a visible difference relates to an appearance that's different to the norm, and I say that in quotation marks, a societally prescribed norm. Craniofacial conditions fall under the concept of visible differences, as they often bring that kind of difference in appearance that people might have to navigate. Nicola and I and the craniofacial team at CAR, of course, focus on craniofacial conditions. And importantly too, at CAR, our research has an applied focus, so we don't do research for research's sake. We do research that leads to actionable outcomes, so materials that are produced, resources for families, support materials for health professionals, and we really enjoy having that very kind of actionable outcome from our research. And I did just want to do a quick plug. We do have a CAR podcast. It's called Appearance Matters, the podcast. We have a few craniofacial specific episodes on there that I'd encourage you to check out if you are interested. Very briefly, just to introduce you to the very small and mighty craniofacial team here at CAR, led by Dr. Nicola Stock, of course, but we also have Jade and myself. We're both research fellows that work with Nicola on the broader kind of psychosocial impact of craniofacial conditions. We mostly have historically focused on cleft lip and or palate, but in more recent years have begun to kind of broaden out into other rarer craniofacial conditions, including craniofacial microsomia and craniosynostosis. Yes, another really important, thank you. Another really important aspect of our work, and that we wanted to stress today, is that we emphasize the collaborative element of our work. So we work with clinicians, other researchers, charities, and other NGOs to kind of work together and produce the best outcome. And then most importantly, we also enjoy working with individuals affected by various craniofacial conditions and kind of really collaborating meaningfully with the community to ensure that everything we produce is acceptable and appropriate. Thank you. Thank you.
Thanks, Bruna. That's a very whistle-stop tour of CAR and our team, beautifully introduced by Bruna there. So just to think about defining psychosocial health and what we actually mean when we say that, to set the scene for the remainder of this presentation, we tend to fall back on the World Health Organization definition of this, and to really emphasize that health is a state of complete physical, mental and social well-being. So when we're thinking about comprehensive cleft care, and I know I'm speaking to the converted with this audience, but it's not just the medical aspects of care that we really want to focus on, it's all the kind of more holistic aspects of care as well. And again, I'm sure I don't need to impress upon you the importance of psychosocial health for comprehensive cleft care, But just to really draw attention to, I've picked out here 3 of your key organisations within the Circle of Cleft Professionals as 3 examples. So Transforming Faces in their mission state about the importance of full rehabilitation and community inclusion. Smile Train emphasis that they want every child to have the opportunity to live a full and productive life. And the European Cleft Organisation speak about lifelong access to quality care and equal opportunities. So really, I wanted to bring this to your attention because we would argue strongly that without the inclusion of psychosocial care, you really aren't going to be able to achieve these missions in full. And so therefore, extremely important aspect of comprehensive cleft care. And then when we think about the different components that contribute to psychological health in cleft lip and palate, what we really want is for everybody to have a positive outlook on their life. We know that having supportive relationships and being engaged in social activities is extremely important for well-being. People having access to equal opportunities in terms of educational and vocational opportunities. Feeling satisfied, personally satisfied with the way that they look and also with their speech and hearing and other aspects of the condition. Also having emotional well-being generally and also having a kind of a sense of resilience and also having had positive treatment experiences. And we know that all of those things are important for most of us actually, whether we have a cleft or not, all of those aspects are important. But in cleft, some of those things may be more significantly impacted or maybe a bit more relevant. But also it's important, I think, to acknowledge that within this all needs to be taken within context. So the environment that an individual is living in and, socioeconomic status, for example, and attitudes and perceptions towards the condition, all of these things will have an impact as well.
Okay. So in terms of what the literature suggests might be some of the commonly experienced psychosocial concerns for, firstly, I'll discuss families impacted by cleft lip and or palate. So upon receiving a diagnosis of cleft in their child, it's not uncommon for parents, carers, and specifically mothers to experience a range of difficult emotions. And these might include shame, grief, sadness, guilt, especially for mothers, again, thinking about, well, what led to my baby being born with a cleft? Was it something that I did? And denial, so not being able to accept their child's diagnosis, which we know has implications for then the behavior that they go on to engage in. Fear for the future is also not uncommon. So what treatment's my child going to have to undergo? What's that going to mean for the family? Potentially, what's that going to mean financially? Will they ever have relationships? Will they go to school? The fears really can be endless at this stage. In addition to having all these negative emotions to kind of figure out and work through, families may also be dealing with societal stigma. So stigma from others, from friends, from other family members, from those that they don't even know, just members of the community. Stigma, judgment, why was your baby born like this? What does it mean? And often that comes from a lack of awareness and education. In addition, parents and caregivers might be experiencing challenges to providing essential care to their child, so feeding, especially when a cleft palate is impacted, that might pose some challenges. Linked to feeding, we might see that mothers especially, but parents are struggling to bond with their child. And because of the diagnosis and because of potentially feeding difficulties, that becomes more difficult. The literature might also suggest that this exacerbates opportunities for family conflict, in the breakup of relationships and marriages even. And then you've got kind of those broader challenges of just access to care, financially, is the family able to access the care that their child needs? Is it easy to access? Does it involve a lot of distance traveled between appointments? Do they know where to go? Are the specialists available for them? Associated with that comes the burden of care. So even once a family finds the right provider, medical provider for their child, what does that involve? Is it several appointments? Is it several follow-up appointments? What are they having to do at home to help their child manage? And then treatment-related anxiety. So especially during those primary surgeries, a small, tiny baby kind of being taken for quite a significant operation, what does that mean for parents and families? How are they managing through that experience? And then, as Nicola just said too, it's really important to remember that Psychosocial well-being and how people are doing psychologically is really dependent on context. So all of these examples that I've just given may manifest differently, or even maybe slightly worse in the LMIC context, where resource may be particularly lower and other issues might come into play as well. Thank you. And just for individuals too, so kind of as the individual continues to grow and move beyond the family, some of the commonly reported psychosocial concerns in individuals with a cleft include isolation and exclusion from others, especially kind of earlier on in their early adolescence. Linked to this is teasing and bullying. So kind of having those really difficult experiences in school. For some with a cleft, communication might be impacted, especially when hearing might be an issue and when the palate is affected as well. So is that individual communicating properly? Are people communicating with them as they might like? For young kids with a cleft, we might see some challenging behavior, and we might have concerns around kind of developmental capacity at that point. Education and educational attainment and performance is also something that the literature often cites may be a concern. As with families, it's common for individuals and even young people with a cleft to have treatment-related anxieties. So generally, in a UK and Western context, definitely, by the time an individual, a young adult reaches young adulthood, they would have had several operations and several kind of interventions with a multidisciplinary team. So there might be some treatment fatigue there. Excuse me. There might also be kind of post-traumatic stress happening around medical and hospital environments. In terms of just well-being more broadly, we could see self-esteem be impacted, heightened appearance concerns due to the scars that are left following surgeries, social anxiety that might relate to earlier kind of social difficulties, symptoms of depression, which will impact the way that that person then moves through life. And then thinking into later adulthood too. So relationships, having a marriage, kind of having a family, rather, starting a family, are there issues and concerns around genetics and their child also being impacted by a cleft? And then also job opportunities and navigating workplace more broadly when having an additional health need.
So that's a wealth of challenges that our families and individuals might encounter from kind of the very early stages around a diagnosis all the way through the lifespan, really, into adulthood. And so once we are aware of what those challenges might be, the next step really is to try to identify those in practice. So how might we go about that? One of the arguably most helpful ways of doing this is to use screening tools, so to look at some of the measures that are available. And to do this, we've done a lot of work on trying to identify which ones are the most appropriate in terms of identifying the issues that Bruna's highlighted here. And to assess those measures, we've looked at what the psychometric properties are. So is what we're measuring valid? Are those measures reliable? On more than one occasion. Also in terms of their clinical utility. So do they relate to clinical practice? Do they mirror what you are seeing and what your patients are coming to you with? And what information are you going to gain from that? It needs to be useful. You don't want to put unnecessary burden on your patients and families, and also on your treatment team, unless the information that you're getting is really valuable. So again, we need to think about pragmatic considerations such as patient burden, but also the time that it takes for you to score and enter any data, do any analysis you might need to do to be able to use those findings effectively and integrate them into your practice. We also need to think about the cost and the availability, particularly in LMICs, and things like translation as well. And a decision that needs to be made is, who is your informant? Are you interested in hearing from the parent? Are you interested in hearing from the child themselves? Or are you interested in both? So those are some of the considerations that we've made. And I would also say another very important one for me is whether there are available normative data. So for example, if you're interested in measuring appearance, If you look at somebody with a cleft, they may score in a way that makes you concerned about their appearance, until you then compare them with another 16-year-old who doesn't have a cleft, and then you see that actually that's just a normal part of teenage life, is being dissatisfied with your appearance. So having that kind of normative data to put it in context is also very important. So in terms of some of the measures that we've identified, and please don't worry about trying to note all of this down, we're very happy to share any resources following this webinar today. But just to give you an overview, we have a number of measures that we use. So firstly, in terms of families, we ask parents to complete these measures. They're focused initially on parental well-being. So we're interested, for example, in how they feel their child's condition is impacting them on a range of measures, including, for example, their social well-being, their emotional well-being, their physical health, and so on. And that gives you a really nice comprehensive understanding of how they're doing. Also looking at symptoms of anxiety and depression, and the hospital measure and the Edinburgh postnatal scale are both really good for doing this. We also know that families have a heightened level of stress. So again, trying to understand who might be most at risk of higher levels of stress, and to identify them and to be able to act on that. That's a good measure. We can also look at aspects of resilience as well. So kind of the flip side of that can be useful. And then in terms of whether they're satisfied with the healthcare that they're receiving, the Paediatric Quality of Life Inventory is a very useful one. And then we also have a measure which looks at their perceptions of cleft lip and palate. So how are they appraising this condition? What impact do they think this is having on their life? And we see that that can have a very strong impact on how their well-being more generally. We also look at the child's well-being, of course, and we have two ways of doing this. The first is for the parents to report by proxy. And so the two measures that we recommend for that is the Strengths and Difficulties questionnaire and the Ages and Stages questionnaire. They are both extremely well validated around the world, and there are lots of normative data that you can compare your children to see how they're doing in comparison to the general population as well. And then, of course, we have self-report, which often can be done from the age of 8 years and up, although obviously you'll need to judge whether you feel that that child is able to understand what they're being asked to do and to provide answers that will be useful to you in practice. But again, we look at psychological well-being, so symptoms of anxiety and depression, their self-perception of their own self-esteem, their own social integration, their own academic performance, for example, how they feel about their hearing, their appearance, and their speech. And again, looking at levels of resilience and optimism. And also they can also complete the Strengths and Difficulties questionnaire. So that's quite a nice one because you can have multiple perspectives on that. We do also support the CLEF-Q in terms of treatment outcomes in particular. So if somebody's trying to make a decision about whether to have a surgery or not, or what type of surgery to have, we think those can be particularly useful. And again, looking at the individual's perceptions of their condition. So what impact do they feel this is having on their life? And that can be a very strong predictor of how they're doing overall. So we're very aware that that is a very large battery of comprehensive and standardized measures, and that can feel quite overwhelming, especially when you're new to something like this. And so particularly with LMIC context in mind, we are proposing this tiered approach. So tier 3 is kind of that top of the tier where you have a team with a very high level of resource. They probably have a psychologist as part of the team, and those measures can then be utilized for research and also for audit as well. So that much higher level of use of measures. Oh, somebody doesn't like that approach at all. Let me finish first before you make a judgment. So then the second tier is kind of in the middle. So it's looking at informing clinical practice. So we're looking there to really help you make some medical decisions in collaboration with your patients and families. So understanding where they're coming from, what their emotional burden is, and how to integrate that into making decisions about what treatment is right for them and when and how, etc. So that's really for teams with a medium level of resource. You may have a psychologist, you may not, but generally speaking, you feel confident enough to be able to deliver that that level of care. And then tier 1 really is a much more entry level approach. It's aimed at promoting person-centered care. It's a starting point for teams who have never done this before. So particularly aimed at teams with low resources. And really what that entails is a set of very basic questions, some of which Bruno will talk about next, to facilitate that conversation with your patients, with your families, to start talking about psychosocial care and opening that door. But it's all still based on the same measures. So regardless of the level of resource that your team has, you can still participate in something that is much bigger and broader, and you can have a stake in that, even if you don't have a high level of resource.
Okay, thank you. So as Nicola said, the tiered approach allows different teams to judge kind of where they feel they sit based on resource and capacity. But we do understand that the concept of measurement, especially in an LMIC context, more broadly poses several challenges, including the fact that these assessment tools were developed and tested in Western contexts. And we've talked about how context is so essential to well-being. So stemming from this, for teams that LMIC teams and also teams that feel that they sit at the level 1 or kind of even below of the tiers that Nicola's just talked about, I'd like to just pose these 4 questions that could be used to initiate a conversation with families, with individuals about psychosocial well-being. So with parents, it could just be, having a child with a cleft can be difficult, can pose some challenges. Can you tell me how you're feeling about your child's cleft now? So a non-judgmental kind of open question that might lead to that conversation. What are you most concerned about? What feels important to you? Is there anything I can help you with today? So opening that kind of element of I'm here to support you, and I invite you to speak to me on these issues. Do you feel like you have enough support to take care of your child and to manage any challenges associated with your child's cleft? So kind of looking to, again, bridge those gaps. And then 2, what we wanted to note is just some things that potentially could be helpful in looking out for in clinic that might be signs of distress and might be signs of, especially, this individual, this family need to be having those conversations. So is the parent alone? Is the parent coming alone to their appointments frequently? I do apologize. Is the parent or the patient upset? Do they seem agitated? Are they quiet? Do they seem in denial? Are they dismissing any type of challenges that they might be experiencing? For LMIC context especially, is the parent or the patient malnourished? Are they having that very basic level of care met? Is the parent not responsive to the baby? Is the baby crying and the parent doesn't seem to mind, doesn't kind of respond? And is there a frequent pattern of missed appointments? That could also be a sign of definitely disengagement from treatment, but also that something's kind of not functioning as well as it could be. And then just thinking about too, the issue with doing this in an LMIC context, as I noted earlier, the evidence base that we work from comes from Western research, predominantly UK, US, and Australia, but also some other European countries. As we've talked about, context is important. Cultural differences are important, both to well-being, but also to health behaviors. In addition, the measures that we've just spoken about may not be appropriate. There might be cultural nuances that mean that they're not appropriate in a non-Western context. Or it might be that they don't ask specific questions that actually in a different context are really important to ask about. In addition, you've got that language barrier. So these measures generally are available in English. If we're lucky, some have been translated, but lots haven't. So what does that mean? And then 2 other access barriers, so cost. So although cost is something that Nicola has featured into the decision-making around the measures that sit at each one of the tiers, some of them do have cost attached. So what does that mean for teams where resource is low and whether other things have to be prioritized other than screening tools? So I did just want to highlight these issues to think about, and really this leads us into lots of more work that we need to do to be able to do this well in non-Western contexts.
Yeah, thank you, Bruna. So we've got a lot more work to do, but hopefully this gives you a starting point. Hugh, just to flag, I probably still do have 5 or 10 minutes to go. Are you happy for me to continue, and stop me if we're overrunning too much? Thank you. So in terms of how we address some of these psychosocial challenges in families and individuals, this is a lot of text, but I'm going to walk you through it. I think there are many things that every member of a CLEF team can do in order to facilitate psychosocial well-being, and I also believe it's the responsibility of every member of the team to facilitate psychosocial well-being as well. So I think regardless of your level of resource, and irrespective of whether you have a psychologist on your team or access to one, you know, that you can refer your patients and families to, hopefully some of these are things that you can all do on a regular basis and begin to practice, so that you know, that level of care is being integrated. So in terms of families, it's really important to talk to them as soon as you possibly can after the diagnosis. You really want to get in there first. You are the specialists. You know the most about this condition. You want to be the one to imprint really what is going to be the way the family thinks about this condition really for the rest of their lives. So it's important to do is to show empathy, really listen to them, reassure them that the cleft is not their fault, and really normalize any emotions that they might be experiencing, regardless of what those emotions are, even if they're quite difficult and dark. That's, you know, it's normal to have those responses to something that is really difficult. And just knowing that, I think other families experience those emotions following a diagnosis can really help families to adjust. You can also provide written and verbal information about cleft and the likely course of care. I think it's important to be upfront from the beginning what this condition entails. That's not to go into lots of detail. Different families want a different level of information at different times, but to really give them an understanding that this is, you know, potentially going to be a fairly long course of treatment, but that your team will be there for them the entire way. And also different people taking information in different ways, so offering that information in different formats and at different time points, and consistently reinforcing that can be really helpful as well. Expect them to have lots of questions. Make sure you check in to make sure that they've understood what you've told them. I think to be aware that adjustment times and people's coping strategies can vary quite a lot. So one person may respond in one way and someone else in another, but that doesn't mean either one is right or wrong. They're equally valid, but for you to be aware that can really surprise you sometimes. It's really helpful to inquire about the family's environment, especially I think in LMIC context. You know, do they have accommodation? Do they have access to enough food? Do they have access to transportation, so that you can understand what that family is bringing and where they're coming from, and the different factors that might impact how they cope with this diagnosis and the care involved. You can signpost them to any local or international support organisations, and connect them to other families, particularly families that are ahead in the treatment pathway, so that they can share experiences and gain some reassurance. There's nothing like hearing a story from another parent to reassure somebody and to really kind of have that level of insight. You can also teach families to practice confident communication in terms of how they manage other people's reactions to the condition. So they will undoubtedly have sorry, through me. They will undoubtedly have different responses from the community, as Bruna mentioned, from family members. So it's just about giving them a narrative. This is the condition, this is what it means, and then kind of moving on, moving the conversation along, just to give them that confidence that if somebody does mention it, they know what to say. They're not going to be thrown by that, and that's not going to be too much of an upsetting experience for them. Again, you can ensure the information that you give is consistent, and you can involve families as much as possible in treatment decisions, you know, explaining what the options are and helping them to come to a decision, an informed decision that is best for them. In terms of children, it's important that the information you're giving is accurate and that it's developmentally appropriate. So that they have an understanding of what their condition is and what the treatment involves. Explain to the children, you know, who you are, what you're doing, when it's going to happen, where it's going to happen, why you're doing it, how it's going to happen. you know, the absolute number one thing, if I can ask you to take anything away, is to talk to your children directly, because they are hearing everything you're saying and they're taking it all in like little sponges. So, you know, as open as you can be with them and as much as they can take away, I think is important. As Bruna mentioned, not assigning value to appearance. So sorry, we haven't covered that yet. Bruna will cover in a moment some terminology considerations. So thinking about the language you use and the impact that has, and avoiding any kind of differential treatment, that they're special or unique. Sometimes that can have a negative impact, even though it's well intended. You can signpost them to available resources, particularly if there are handouts with pictures and videos, you know, something that's more accessible for children. You can assess developmental milestones, and we've talked about some of the measures that might be useful for that. Also thinking about their readiness for school or work, and to work with schools as well, to ensure that they're able to actively participate, that they're not being excluded, and that they can participate when they're there. And also helping families, again, to create a short response to comments and questions that the child can use, so that the child can feel confident in acknowledging it, explaining what their condition is, and then moving the conversation on. So again, they're not caught out by any kind of comments or upsetting questions. In terms of adolescents, I think the best one you can do is to involve adolescents in treatment decision-making, let them take some ownership of that, you know, explore their goals. What is it that they want to achieve? What are their motivations for having a particular treatment? What are their expectations of the outcome? Is that expectation realistic? Also thinking about maybe to expect some burnout or some fatigue in terms of treatment. You know, at that point, they may have had quite a lot. Or maybe even the opposite, so some impulsivity. I'm being bullied at school and I want surgery to fix it. Maybe surgery is not the answer. Maybe they need to talk to somebody first and assess that properly. And really help them to understand the extent of the surgery that they're going for, or the treatment, the recovery period and the anticipated changes, particularly if that's related to appearance, because that can be a process to adjust to in itself, to have a face that is different after a surgery. Trying to discuss mental health with adolescents on a one-to-one level. If their parent is present in the room, they're going to have a very different response to if you ask them one-to-one. Try, if you can, to minimize the impact of treatment on other areas of life. So, for example, do they have exams coming up? You know, thinking about that and thinking about when you schedule appointments and treatments and surgeries can be really helpful. Checking in about their academic performance and are they enjoying school? Are they engaging in school? Can be really helpful. They spend a lot of their time there. So that's an important question to ask. Be open to discussing dating experiences. One way of opening this conversation is, you know, oh, so are your friends dating anyone? And then that might open them up to talking about themselves as well. And then also to have a really clear plan for transitioning into adult care and really them taking responsibility for those decisions going forward and kind of managing that adult side of care. Another transition to consider is to higher education or the workplace. This can bring additional challenges. Also offering information on family planning if you have access to genetic counsellors. That can be very helpful in terms of helping them to think about that in advance and what the risk of recurrence might be and what that means to them, and then offering support accordingly. Assessing their confidence in managing adult care. Do they know who to contact? You know, they might be absolutely done with treatment now, but in the future, that, you know, if they want to come back, do they know who to call? Do they know what questions to ask? Offering ongoing support into adulthood. So I suppose not quote unquote discharging them, but ensuring that they know you are there as much as possible throughout their lifespan. If they do want to return to treatment later, you know, they can always get in touch with you if that's feasible for you as a team. And to make sure, again, they have that kind of information to how to get back in touch with you in the future if they need to.
Very quickly, this is our last slide and then we will be finishing up. But something else that we think is really important when working with patients and with families is terminology. And we're coming at this from the perspective of kind of looking at how language can actually really impact the way in which an individual views their own cleft, or a family or a parent views their child's cleft. So in thinking about the terminology that we use, terms such as disfigurement, abnormality, anomaly, deformity, defect, all of these terms are assigning value to this health condition, right? So it's even if that's not the intention of the health professional who's engaging in these terms, and in kind of medical care and in surgery, these are terms that you'll see a lot and in manuscripts. But what does that mean for the individual receiving that and hearing that and the family? When we think about surgery as well, so the initial surgery, you might often refer to it as the primary repair. So when we think repair, what does that mean? Does it mean that something was broken, needed to be fixed? So we can think about actually all of these really small nuances to language, and think about how we can actually engage in much more inclusive language, and anything that insinuates normal. So we're going to do the primary repair to make your lip normal again. That's of course something we'd never want to say. A child who has a cleft is normal, they just have a cleft, and they might choose to engage in treatment. So instead we can use terms such as visible difference or craniofacial condition, or cleft lip and palate, cleft lip, cleft palate, terms that don't have any value assigned to them. And I apologize to the interpreters for, I'm not sure how the translation will look for these terms, but I hope that that's happening. And so just some examples also in centering the person, so person-centered, person-first language. So cleft child versus the child with a cleft. Alveolar ridge defect, or an opening in the bone in the gum line. So these are all really small changes that might take some conversations within the team, but we think can have a really significant impact on those initial communications with patients and families that will really distinguish how they go on to cope going forward. So just to think about that also.
Fantastic. And I think we do, yeah, this is perfect to get to your last slide. We don't want to cut short. There's just so much good context there. So a huge thank you to Dr. Nicola and Dr. Bruna for this overview. And you can see how to get in touch with them there. We've had lots of chat about, oh, this is really rich. I'd like to see it again. So just to reassure everyone, this will be uploaded to YouTube later this week on the COCP channel, which you all should have access to, but someone from the team will be able to post that link to that YouTube channel in the chat even now. So great. So we'll we'll stop sharing our screen there, if that's all right. We'll jump back into what we have here, and I really want to hear from the group. You know, thinking about what really stands out for you in terms of what they've brought up. Are there elements that you'd like to ask some questions about? And you know, going forward, you know, what are some ideas that you take away? I think we'd all love to hear that in the 15 minutes that we have left. So a quick reminder, we do have some people for whom Spanish is their first language. So in that case, if everybody could go down to the interpretation button that should be at the bottom of your screen, if you're not using a cell phone, it's somewhere else if you're using a cell phone, and click English. That would mean that if someone asks a question in Spanish, you'll automatically hear the interpretation into English, and we can seamlessly move back and forth, which our lovely colleagues in Chile will be able to facilitate for us. So excellent. So feel free, as we mentioned before, can you please, you can signal by raising your hand. You can type a question right in the chat. You can turn your video and ask it that way as well. And but we'll get started. Well, Dr. Michael from North Carolina, please feel free to kick us off.
Thank you very much, Hugh. That was just a brilliant presentation. Thank you for letting me be a part of that. I often use the terms, and I felt comfortable doing this with my kids, saying, and to the mothers and fathers, all the parts are there. They just didn't get together in the right way. And everything there is normal. Your lip is all there, all the muscles, everything is there. We just have to put it together the way it usually is put together, the way it is on the other side, if it's a unilateral cleft. So I didn't say that it was, and I didn't use the word repair for exactly the way you pointed out, but telling the parents, everything is there, all the parts are there, we just have to put them where they belong. And that was a pretty non-threatening way. And then the moms, I felt, and after years of talking to moms, and mostly moms about it, who felt almost all the guilt, is that they would say, oh, okay, it was just something that didn't quite work out, but everything is right that's there. It's not like they're missing, at least for cleft kids, it's not like they had agenesis or missing of an ear or an eye or an arm. They felt good that this was, everything's there. They just had to have somebody come put it back in the right spot. So that
Thanks,
was my
Dr. Michael.
comments. Well done, you two. Holy cow. What a great presentation. Thank you.
Very good. We'll keep moving before we hear a little bit more from Dr. Stock and Dr. Bruna. One of the questions, and we know this, we follow this in the chat, that very few of the scales that you mentioned are in active use, at least that we know of, in LMIC context. Is there a particular scale that you would recommend if a team is thinking about starting to move more in an evidence-informed approach? You know, what's one that would be potentially accessible or a good starting place? Would you imagine?
This is such a sorry, hold on.
So I think you have two.
Some feedback. Sorry about that. This is such a difficult question to answer, and it's one that we get all the time. But I still struggle to answer this because I think as psychologists, we like to make everything complicated. So everybody would like, you know, one question or one questionnaire, you know, what's the one I can use to kind of get started? And it's really difficult because I don't think there is one. I don't think that exists. And so what I would really encourage people to do, I think maybe as a first port of call is to get in touch with us. We can kind of make a kind of individual case-by-case basis recommendation, but also what we can do is, you know, we can have a think about the answer to that question and maybe a bit more and maybe provide some more written generic support in the form of a handout or whatever might be useful to the audience today so that they have something to take away as well. But it's a really difficult question to answer. And I wish we had a, yes, this is the measure, go and use that one. But unfortunately, we haven't got to that place yet.
Thank you. And I think as you mentioned in some of your limitations for moving forward in this way, that a lot of the research about which scales are valid and useful has been done in high-income country contexts. Could you say a little bit more about that? And what, you know, do you have any suspicions about the utility of moving in focusing more on some LMIC contexts in terms of establishing, you know, a way forward for psychosocial care and an evidence-informed approach?
Do you want to take that one?
Yeah, so yeah, a really big question again. And as we said, I mean, when you think about psychosocial coping and psychological well-being, it's so context dependent that it's a given that kind of the context where these assessment tools get developed is really crucial. We see that also in intelligence testing. You know, you take the standard IQ test that we might use in a Western context, you put it in a non-Western context, those people aren't going to pass and they're going to be rated as not very intelligent. That's not actually true. It just means that the assessment tool that was being used was not accurate enough and appropriate enough. So it's the same here. So we, you know, from working with LMIC colleagues, we hear that stigma around and beliefs around kind of what causes craniofacial conditions such as cleft might be particularly prevalent in non-Western contexts, and that's to do with potentially limited education. So that's one example of something that may not be encapsulated in the current assessment tools, but actually would be worth doing some work on in LMIC context to then ensure that the support that families are being provided is the most relevant and doesn't ignore this huge aspect of their experience.
I mean, all the work we've done up to this point, you know, we've done a huge number of qualitative studies, right. We've reviewed all of the available literature, we've assessed all the available measures, and we've done a lot of work with clinicians, with charities, we've done a lot of work with, you know, families and individuals with cleft, and we've put all of that together over the course of, you know, it's coming up for 15 years now, and we still don't really have an answer, and that's not to say that all of that work isn't extremely valuable. It's had a big impact in terms of Western context, but really we kind of need to not start all over again, but we need to start from that kind of base level of not assuming that our research and our measures and our approaches are going to fit into an LMIC context. What we need to do is go to the LMIC context, work out what the issues are there, and work from the ground up. And we can utilize what we know and what we've learned from Western context to inform that. But we think it's essential that the work comes from the countries that it's based in, and that it's built on that, rather than us imposing what we think might work from Western research.
Thank you. A question from Ephraim. We've mentioned just in passing a few times about the potential for marital conflict or challenges, and even we've mentioned in passing the idea of some of the barriers or burdens that mothers prepare. Ephraim was wondering a little bit more about psychosocial care as it relates to fathers. Do you have any comments on that?
Yeah, so we have done some research with fathers specifically. Some qualitative work. We did some interviews to find out how similar or different their experiences were. And I think the result was that, they are broadly similar, but fathers do experience things differently. I think as well, typically fathers tend to be left out of most healthcare situations. So if we think about pregnancy, a lot of focus is put on the mother and the child, and the father does tend to be excluded from that conversation. So then when you add in the additional medical needs of the child, I think the father needs support as much as the mother, but maybe in a slightly different way. Do you want to add to that?
Yeah, I think I'd just like to add that that's the issues of fathers is a perfect example actually of when we think about working in LMICs in non-Western contexts. So in the work that we've done, we've identified that kind of those at least UK kind of gender norms are influencing the ways in which fathers of children with a cleft are coping and engaging in their child's treatment, how involved they are, how involved they aren't able to be. So what does that mean in a different context where gender roles and gender norms may differentiate further? What do those experiences look like? And that's an example. Yeah.
And sorry, and I think we have done some research. I know our colleague Senem has done some research as well. So it is starting to come together, and it does show that fathers do experience these things differently, and they do need a slightly different type of level of information and support. But they seem to be very difficult across the health board really to recruit to research. And that's partly why we know less about them. But I would strongly advocate and say, that's not because they're difficult to reach, it's because we're not doing enough to engage them. And so that's our responsibility. And it's the same, for research as it is in clinical practice. We need to be doing what we can to engage the family as a whole and working systemically, involving all members of the family and not just focusing on the mother and the child.
Thanks. And I think as we see in the chat a little bit, and definitely came up in terms of the roundtable on psychosocial care, there is a sense that some of that marital challenge or the burden for parents in particular is exacerbated in contexts where cleft is not well understood. And as Dr. Bejoy is saying, even the idea of divorce, in our travels, we hear a lot of stories around some real isolation and estrangement that can happen, really connected directly to the diagnosis of cleft and the understandings of why that might have happened, or some beliefs about who's to blame. A quick comment from Bolivia, especially around the initial moment, and I think that you're saying there isn't a universal tool, but can we just in about 2 minutes can we focus a little bit on, let's say you're not a cleft a psychosocial professional, could you summarize just a couple ideas of that initial moment when you're meeting with a parent? Maybe it was a total surprise to them that their child would be born with a cleft. What are some good practices informed by your research about how to approach those initial meetings that would be grounded in some good pro-social psychosocial care approaches?
Yeah, absolutely. So I can speak to that, but I also know there are some clinical psychologists in the room. So I would also always revert back to them as well as the experts. But I think some of the things we've already touched on really today very briefly is one of the most important things you can do is listen, is to open up the conversation, use one of the questions that Bruna's proposed there. We know that having a child with a cleft can be challenging. Can I ask how you're feeling right now? Is there anything you'd like to talk about? Is there anything I can support you with? Just kind of asking those basic questions. It it gives permission to the parent to be able to share some of that information. It allows them to know that is an acceptable thing to talk about. It's not all kind of diagnosis and treatment and surgery. It's your well-being is just as important, in fact possibly more important. And I think also just reassuring them the cleft isn't their fault, and I know that has different connotations in different cultural contexts.
but also normalizing it. You know, like we said, I think the responses to having a child who has additional needs can vary greatly. And all of those feelings are valid, and all of those feelings are okay, and all of those feelings are very common. So, you know, there's nothing wrong with a parent if they're feeling really depressed. There's nothing wrong with a parent if, you know, they're really struggling to come to terms with this, you know, diagnosis, and they don't want to accept it. Those are all valid responses to something that's very difficult. So I think to normalize that, and to reassure everybody, you know, that is common. You know, other people feel this way, and again, putting them in touch with other parents that have been through that will reinforce that message, because they'll see they're not alone. Other people have been through this before. It will validate their feelings and you know, everything they're experiencing, and it will also give them a different level of advice that you're not able to offer as a health professional, because it's coming from somebody who's lived it before. So I think those are some of the kind of initial thoughts that we would have. But again, perhaps we can provide, you know, a handout or something that would be useful, so that everyone has something to take away and use after this as well.
Fantastic. Oh, yes, sorry. Quickly, Bruna. Yep.
Really quick, I promise. One thing is actually to congratulate parents. So going off the comment about terminology, when we're thinking about, as professionals, the language we use can really shape the way that the parent's journey kind of goes. When a parent has a new baby, it's normal to say congratulations, you know, your baby, you've got a baby. So that goes on that topic of normalizing, of opening that communication for, hey, come speak to me if there are any challenges, but also, you've had a baby, congratulations, you know, how are you doing? That can be really helpful too.
Thank you. Oh, there's so many topics that you've raised, you know, even around terminology in different contexts. You know, we did have some success, as some of you were following last year, in making sure that even Google Translate, you know, would move the appropriate translation away from, you know, the traditional or the historical term that compares a baby's face to, you know, to a rabbit. You know, that even sort of how to be clear about these kinds of things. So we're on a beginning of a journey, I think. But there's lots to discuss there, and even some good comments about, you know, how do we assess, even if we're doing, you know, so psychosocial care through outings or activities, how do we know that whether they're working, or whether they're doing the right thing? So there's lots there. And there was a quick question about how to contact you, but that wasn't the slide. So again, I will emphasize there's a lot to digest here. That checklist was very dense, but so we do encourage you to take time to review this. It will be posted on YouTube, and it's going to be an excellent time for you to engage some members of your team to say, what does this raise for you? So this is the questions we're taking it at. What is the idea from this discussion that's most compelling? You know, what are some things you can share with the other members of your team, especially potentially if there isn't anyone who really owns the psychosocial care aspect? You know, you're all kind of covering different elements. What's the thing that you want to think about? Maybe it's around terminology. Maybe it's around that initial meeting with a parent, and is there a script you can kind of share with each other about what's the best way, what solicits the best results? And then definitely, it sounds like there's some real enthusiasm from the Center for Appearance Research to do some research on LMIC context. So that might be something you might want to reach out to them about. But when I think about what will be your next step. Now, one of the next steps we're really excited about. Tuesday's the day. So you'll see here that in the light of our virtual conference, we do have two different discussions, actually all three really connect into here, whether it's talking to patients about their own outcomes, whether it's parent and patient support groups, or whether it's specifically about integrating psychosocial care across specialties. You have colleagues on this call and beyond who were working for 3 months solidly on trying to get their heads around these ideas and have come up with some lovely starting point guideline recommendations. So this will be free to download. They're short documents that will hopefully be able to start some of these discussions. So stay tuned. They will be officially launched next week, early next week, in English, Spanish, and French. And yeah, any questions about that, obviously it's there, and we'll try to link in also to the work that the Center of Appearance Research is doing. So thank you for that. Finally, you know, thank you so much to our two experts today, Dr. Bruna and Dr. Nicola, for this discussion. We didn't have enough time to keep talking about more. I think that shows us that there's more webinar, more discussion, more roundtable work that's required to move this really important topic forward. And as our our facilitators have mentioned, this is a really important theme within the idea of comprehensive cleft care. So thank you for your interest today. Thank you again to everyone for showing up and making this such a dynamic time, and we'll look forward to seeing you the next time.